Hi everyone, welcome to the channel of Medipath. Today's topic is the celiac disease. Celiac disease is a gluten sensitive enteropathy, or we can say this is small intestinal enteropathy. This is immune response to the gluten, which is present to the wheat, rye, barley, and oats. The global prevalence of the celiac disease is 1.4%. And what is happening to celiac disease if patient, any person, which is sensitive to the gluten, eating gluten rich wheat, rye, barley, oats, the gluten causing the damage into the intestine, which causing the malabsorption, and malabsorption causing the weight loss, diarrhea, and the growth failure. In long run, they are causing the iron deficiency anemia, they are causing the ataxia, migraine, headache, osteoporosis, or all are the growth failure features, growth retardation features in a adolescents, a children, or maybe a young adults. ठीक है, तो in celiac disease there is a deaminate glutamine residue of gluten derived peptides facilitating their representation by the antigen presenting cells and causing the damage to the intestine. Okay, this is the celiac disease. Patient present with the diarrhea, weight loss, and growth failure because of the malabsorption, and maybe sometime bloating, irregular bowel habits, migraine, headache, and ataxia due to the deficiency of nutrients and vitamins. There is also osteoporosis and deficiency anemia, detection of the abnormal development. These are the common symptoms. They are not specific one, but they are the most sensitive and most common symptoms which is present with celiac disease patient. Some of the patient has the association with the type 1 diabetes mellitus, autoimmune thyroid disease, because the nature of the disease is like the allergic or immune based. So they can be associated with the type 1 diabetes mellitus and autoimmune thyroid disease, and most important association is the dermatitis herpetiformis. In dermatitis herpetiformis, this is the skin disorder which has the vascular rash which show the IgA deposition. We can see there is a rash present which is showing the on the exterior surface of the body, which are the vascular rash. On the histology, we can see the neutrophilic macroabscess. Neutrophilic macroabscess is present into the subepidermis. There is a neutrophil collections in the subepidermis. On immunofluorescence, there is a linear IgA deposition. We can see this is the linear IgA deposition. This is the conformity. This is the dermatitis herpetiformis. So dermatitis herpetiformis, the type 1 diabetes mellitus, and autoimmune thyroid disorder. These are very important. They are the very important differential associations of the celiac disease. Sometimes the Down syndrome or Turner syndrome patient also has the increased risk of the celiac disease. Next thing is what is the complication of the celiac disease. Complications are important complication is the refractive celiac disease. In the refractive celiac disease, the patient on the gluten-free diet, but they are not responding to the gluten-free diet. It means they are refractory to the most important treatment is like the gluten-free diet. Okay, we will discuss the topic refractory celiac disease in upcoming slides. More complication, and more rare complications is the T-cell lymphoma, hypersplenism, and small bowel adenocarcinoma. Next thing is the genetics. Genetics is a very important thing because the which patient present with these haplotypes, watch haplotype DHLA, DQ2, and DQ8. Any one of them is present. They are more vulnerable to have the celiac disease. In one line, we can understand by this. If there is a person which has the HLA, DQ, and DQ8 present, there is a two possibility. They can have the celiac disease. They can be normal a carrier. Okay, if these are present. If they are negative, they always will be normal. They never will have the celiac disease. Okay, so we can use this point as a ruling out feature of celiac disease. If any person which have DQ2 and DQ8 negative, they definitely will not have the celiac disease. If this is positive, they can have the celiac disease. They cannot have the celiac disease. Okay, so this is not important for making a diagnosis, but this is important for ruling out the celiac disease. So where will we use this point? If the patient is already on the gluten-free diet, he already under the treatment, the serology or the endoscopy and biopsy will be negative. On this consideration, if we want to if we want to rule out the probability of celiac disease, we put the test of HLA-DQ2 and DQ8. If this is negative, this is ruled out the celiac disease. We have to think about the other differentials. If the HLA-DQ2 and DQ8 is positive, we will follow up the patient and see what will be the thing, because there is a possibility to have the celiac disease. We cannot say definitely will be celiac disease, but there is a possibility. Okay, the thing is very important. Next thing is the patient family members screening. If father has the celiac disease, if the son is symptomatic, the actually DQ2 and DQ8 will help to going towards the diagnosis of celiac disease. If the patient is asymptomatic, so doing this test is very illogical, or still controversial also, because normal populations, 25 to 35% of normal population has the positivity for the HLA-DQ2 and DQ8. So we cannot say कि positivity of HLA-DQ2 and DQ8 in son, which is asymptomatic, which father have the celiac disease, always will have the celiac disease. That's the important finding. So asymptomatic has the controversy, but symptomatic patient, we are seeing the symptoms, father has the celiac disease and the HLA-DQ2 and DQ8 is coming positive, we can think that this will be a celiac disease of this patient. We can rule out the other common things like the infection and these things. What is the pathogens? We already discussed, but we going more deep onto the pathogenesis. And the important thing is that gluten excrete the gliadin come into the intestine, and by the transglutaminase enzyme, this is deaminated gliadin, or this deaminated gliadin is sensitive if there is a presence of the HLA-DQ2 and DQ8. Not always, but more vulnerable. Okay? If there is HLA-DQ2 and DQ8, the antigen presenting cell identify the deaminated gliadin and stimulate the T cells. T cells is secrete the interferon gamma, which damage to the epithelium, and damage to the epithelium secrete the interleukin 15, which also stimulate the CD8 T cells, and which also further damage to the epithelium. So due to the damage to the epithelium, there is a decreased absorption of the nutrients and proteins and carbohydrates and other things, which causing the malabsorption and growth failure and diarrhea. There is also important thing is the T cells also stimulate the B cells, which causing the anti-gliadin, anti-adenomyosin, anti-TGG antibodies. This whole image has all the diagnostic clue of the celiac disease. First thing is the gluten sensitivity. Second thing is there is a HLA-DQ2 and DQ8, which used as a negative predictive, high negative predictive used into the ruling out the celiac disease. After that, there is an important thing is the antibodies, serological markers. Anti-TTG is very important. IgA, anti-TTG is very important serum marker, and anti-gliadin, anti-endomycin is also very good antibody. In the serology, we can test. Or due to the increase in T cells into the intraepithelial concentration, on histology we see the increased IELs, which is very important diagnostic clue on the histology. Okay. There is a loss of villi due to damage concentration of the villus. There is a loss of villi, which also seen in the histology. Okay, so these are the two important features we can see in the histology. So how will you diagnose a celiac disease patient? Patient come to you with diarrhea, weight loss, and the growth failure, which is the adolescence or maybe a child or maybe young adult. You think about the celiac disease, you go for a serological test, which is a very important serological screening test, a test of choice of a screening. This is the IgA-TTG levels, but always do it with the serum Ig level, because the serum Ig level is deficient in a patient, so there is can be a false negative result for the serum IgA-TTG levels. So always we have to do in combined nature, serum Ig level plus TTIG levels. If serum TTIG levels is increased and serum Ig level is normal, we can think this can be celiac disease, and we go for the endoscopy and biopsy. In endoscopy, there is a villus blunting we can identify, and on biopsy we have to find out three important features. These are three important features: the villus blunting, cryptoplegia, and increased IELs. Okay, if the serum Ig level is deficient, so there is no benefit doing the IgG-TTG levels. We have to do the IgG-TTG levels, or we have to do the DGP-IgG levels. Okay, for screening. On biopsy, there are three important features we already discussed: villus blunting, cryptoplegia, and increased IELs. But we have to put on the grading. Mars grading is the very important classification. The first thing is 0. There is no cryptoplegia, there is no IELs increase, and there is no villus atrophy. Grade 1, if grade 1 there is an increased IELs only, there is no cryptoplegia and there is no villus atrophy, there is only increased IELs. Cutoff is different. 400 enterocyte in gradulum is the cutoff is 30 and jejunum is the 40. If they more than 40 and more than 30, we can say this is the increased IELs, and on histology this is the Mars grade 1, but there is no cryptoplegia, there is no villus atrophy. Grade 2, if there is an increased IELs but there is a cryptoplegia is present but there is no villus atrophy, this is a grade 2. Grade 3, if there is a all three things is present but grading at 3A, 3B and 3C. Increased IELs plus cryptoplegia plus villus atrophy is the grade 3, plus villus atrophy is mild, this is the 3A, mark, this is the 3B, complete is the 3C. Grade 4 is the same as the 3C, but different is that there is atrophic crypt, not cryptoplegia. What is the IELs range? IELs range means that the tip of the villi, there is an increased intraepithelial lymphocytes. These are the lymphocytes. The small round cells are lymphocytes, but the long cells are the epithelium nucleus. These are the lymphocytes. 100 enterocyte per 100 enterocyte there is in duodenum there is more than 30 lymphocyte. We can say this is the increased IELs. Okay. What is the villus blunting? This is the complete atrophy of villus, because the villus is identified like this. This is a complete villus atrophy. Okay. This is the duodenal biopsy. What is the treatment? Treatment is the strict gluten-free diet. That is the treatment. Nothing else you have to do. But there is a fourth scenario. First scenario is that patient on gluten-free diet, patient well respond by the symptoms. Symptom all are resolved. What you have to do? You have to do the serology and the biopsy for follow-up. Only one time, not regularly. Only one time to confirm the there is a villus is responding to the treatment on biopsy also, on serology also, or symptoms we are seeing they are responding. So we have to do the serological follow-up and biopsy follow-up only one time for documentation of completing the villus atrophy. Nothing else. If the patient without symptom resolution comes to you, okay, there are two probabilities. First probability is the patient not following the strict gluten-free diet. Okay. The most common cause is the residual disease activity dietary not adherence. The patient not following the strict guideline of the treatment. Second thing, it can be other disease or it can be a refractory disease. Okay, the patient symptoms is not resolving. So biopsy to require these things. We have to always do the biopsy. In biopsy, we have to see the disease activity. We have to see the other causes to rule out. Okay, for diarrhea, or we also have to rule out a T-cell lymphoma or refractory celiac disease by the immunohistochemistry. Okay, we have to do the patient is not resolving the gluten-free diet. Second thing is the patient biopsy is negative, but symptoms also persist. It means patient on the gluten-free diet, patient symptoms is not resolving but biopsy is negative. What does this mean? It means that patient has the different diagnosis rather than the celiac disease. So we have to rule out the other diagnosis, or we have to rule out the coexisting disease. It may be possible that there is a celiac disease plus there may be other disease. So the biopsy is negative, but symptom is persistent. If there is a symptom, there the biopsy on the villus. On the biopsy, there have to be villus blunting, but there is no villus blunting. It means the patient may have the other differential, other diagnosis, or the patient may have the other coexisting disease. So this is the including irritable bowel syndrome, microscopic colitis, small bowel bacterial overgrowth, lactose intolerance that can also be possible. The patient symptoms consistent with the celiac disease, but negative serology, negative biopsy, and no evidence of the wheat allergy also. It means patient have not the wheat allergy overall rule out. It means the sensitivity is for the gluten only, but biopsy and serology coming negative, but symptom is there. Or symptoms also importantly consistent with celiac disease and responding to the gluten-free diet also. It means this is gluten sensitive enteropathy, but this is not the celiac disease, because the serological marker and biopsy not showing any feature of the celiac disease. This is the non-gluten sensitivity, non-celiac gluten sensitivity. This is not the celiac disease, but this is the gluten sensitivity. Or this is also not wheat allergy. Wheat allergy is a different thing. Okay, not related to the gluten. Okay, So upon discontinuation of the gluten, they have relief of the abdominal pain, headache, migraine, and disease symptoms. But etiology of this disorder is also unknown till now. Okay. Of the patient not responding, the possibility of refractory celiac disease we already discussed. This is a very important complication. But this is this is the most common complication. 10% patient will have this as a persistent activity disease. They have the persistent villus atrophy, absent 1 year follow-up of strict gluten-free diet. They have the two types of the. They also have the negative celiac serology also confirm adherence to the gluten-free diet. So negative serology होगी, but the biopsy not responding, symptoms not responding. Two types: type first, type second. Type first means there is a normal phenotype CD3 and CD8 positive. Normal phenotype of T cells in the intraepithelial lymphocytes. But aberrant CD3 and loss of CD8, this is the type 2 refractory celiac disease. What is the type 1? In type 1, they are polyclonal T lymphocyte which are CD3 and CD8 positive. They are very good response to the steroids and the immunosuppressant. They have very less chances of to develop the T cell lymphoma also. Okay? So in fibro, very low chances of T cell lymphoma. There is a risk of lymphoma low, prognosis very good. They are responding to the very importantly is the steroids and immunotherapy. Immunosuppressant. Okay? The mild to moderate malabsorption clinical severity, % immune activation. But type 2 refractory celiac disease have the aberrant CD3 and CD8. They have monoclonal T lymphocytes and premaglial lymphoproliferation disorder risk is very high, and T cell lymphoma risk is very high. 33 to 50% patient can have the T cell lymphoma, but they are not responding to the steroid or immunosuppressant, but they are very severe phenotype. So how will you treat the type 2 refractory celiac disease? We have to use the cladribine, we have to choose the chemotherapy, stem cell transplant, and surveillance for lymphoma also, because the very high risk of the lymphoma into the type 2 refractory celiac disease. But in type 1 we can use the steroids. No need for the cladribine and chemotherapy. Surveillance for lymphoma and stem cell transplant also we have to don't do that into type 1 refractory celiac disease. This is all over about the celiac disease.